So again, welcome to the 2018 Parkinsons Symposium, and the 2018 is Neuro Challenge Foundation's 10-year anniversary. And so, yes. And even though the Symposium has been a long-running educational program, this is our second year offering the program at no charge. And we're able to do that thanks to the generosity of the communities we serve and some of our very important community partners who are here today. So I have to take a moment to acknowledge them. We want to give a very big shout out to our partners at the Ross Camp Institute and Ross Camp Institute Clinic as our presenting community partners. So thank you, Ross Camp. Their table is in the back of the room. Ross Camp Institute, you're going to hear a little bit more about them in just a moment, but they're one of the best kept secrets in our community, and so make sure you get to know them better. I'm very proud to tell you that Neuro Challenge offers more than 30 monthly programs at no charge, in addition to a symposium and all of the other special events we do. The other sponsors that I want to thank that help make that possible is Acadia, Impacts, US World Meds, the Elaine Gorbach Levine Foundation, Care Patrol, AbbVie, Medtronic, UCB, Lundbeck, Seniors Blue Book, and Tidewell Hospice. If you want to show your appreciation for the people who support these programs and help us to offer them at no charge, you can do that by visiting them and getting to know them a little better. So we're very grateful to have them here. And very grateful to all the volunteers who helped us set the room up yesterday and helped everybody get in today. So can we have a round of applause for the amazing volunteers? And my greatest thanks goes to our partners at Sarasota Memorial Hospital, who have devoted so much staff time and resources to help us make this event a huge success each year. Sarasota Memorial Hospital was Neuro Challenge's first partner when the organization started 10 years ago and has helped us to grow and reach and serve more people in more communities. So we're very grateful for their continued support. A special thank you to Wanda Jackson from SMH, who's right here in the back. Many of you know Wanda. Wanda truly loves the Parkinson's community, and we're fortunate to have her on our team as well, helping us plan these events. I also have to thank the amazing Neuro Challenge Foundation staff. And so we've got Carissa Campanella, our program manager, back in the back. We've got Cindy Underwood, our Manatee and Pinellas care advisor in the back. Carla Brody, our Sarasota and South County care advisor. And then my biggest thanks today is going to go to Sarah Weinberg, our operations manager. Many people this morning said, oh, wow, thank you for setting all this up. I was like, I didn't set up anything, actually. They made me leave yesterday when I tried. And yes, one of our volunteers just reminded her whole table that I was in the way. And I was, so I left. It's okay. So while I have your attention, I want to take a moment to tell you about Neuro Challenge's largest educational event to date that will be happening on April 14th, and it is the Parkinsons Expo. This event is a day-long event that is designed to educate, engage, and empower the Parkinson's community. We are bringing in the national thought leaders of so many topics that are so important to each one of you. We take your surveys, we take your feedback, and then it helps us to create these programs. So on your table, everyone has a flyer for the Parkinsons Expo and has a registration form. I encourage you to please, if you are interested in the event, to fill out your registration form and leave it at your table today. We are expecting 1,500 people to attend this event in April, and we're so very excited to be able to provide this to our community and, once again, All of our programs and services are provided at no charge, so we hope to see you there. This program has been a long time in the making, and so we're happy to see it all come to fruition. There's more information also available on the Neuro Challenge website. At this time, I would like to invite James Karen, the Outpatient Rehabilitation Manager of the Sarasota Memorial Healthcare System, to say a few words.
Good morning. Welcome to the annual Parkinsons Symposium. I'm Jim Karen, the Outpatient Rehab Manager and a Physical Therapist here at Sarasota Memorial. We are so glad you are here with us today for this great event. We are privileged to work together with the Neuro Challenge Foundation for Parkinson's to bring you this event as well as many other wonderful programs to the community. We have partnered with the Neuro Challenge for 10 years, and I can assure you that this organization has the passion for serving and advocating for families affected by Parkinson's. Together with Sarasota Memorial, we strive to bring you the best rehabilitation through our LSVT Big and Loud programs, educational programming, and support. I wanted to thank our outstanding Sarasota Memorial Rehab team, consisting of physical therapists, occupational therapists, and speech therapists, which many of you are here today. Our Health Fit team, Symposium committee, speakers, and sponsors for making this annual symposium something that always speaks to the needs and requests we hear directly from all of you. You are our focus, and we are so glad you're here today. Welcome, and I hope you all enjoy this symposium.
Thank you, Jim, very much. So before I introduce our first speaker, Dr. Andrew Keegan, who is the Clinical Medical Director at Roskamp Institute, I want to tell you a little bit more about the Roskamp Institute and read the following statement provided to us. The Roskamp Institute is devoted to understanding causes and finding cures for neuropsychiatric and neurodegenerative disorders. The Institute utilizes a broad range of scientific and clinical approaches to understand the causes of and potential therapies for these diseases. The quality of research performed at the Institute reflects its motto: better science, real discovery. The Roskamp Institute also hosts a full-service neurological clinic specializing in the diagnosis and clinical management of conditions such as Alzheimer's disease, Parkinson's, mild cognitive impairment, multiple sclerosis, and many other neurological and neurodegenerative disorders. The clinic also contains a clinical trials division which provides clinic patients cutting-edge participation opportunities in a multitude of therapeutic areas and phases of pharmaceutical and nutraceutical clinical research. Partnering with Neuro Challenge for the 2018 Symposium is a privilege for us at Roskamp and reflects our joint passion to educate the public and to discover safe and effective new treatments and diagnostic tools. Again, thank you, Roskamp Institute, for being our presenting community partner. So we are very delighted to have Roskamp's Clinical Medical Director, Dr. Andrew Keegan, as one of our speakers today. Dr. Keegan is a board-certified neurologist. He conducts translational research in neuroinflammatory and neurodegenerative diseases, such as multiple sclerosis, traumatic brain injury, Alzheimer's, and Parkinson's. He received his bachelor's degree from Rensselaer Polytechnic Institute, his master's degree from the University of Illinois, and his medical doctorate from Tulane Medical School. In addition, his internship and residency were performed at Washington University. And something I just want to add is that Dr. Keegan is a wonderful friend and supporter of the Parkinson's community, and we're very happy to have him here. Dr. Keegan?
Thank you, Robin, and thank you for that kind introduction. Thank you for inviting me here to speak. I'm a general neurologist at Roskamp Institute and honored to also be here to speak with Dr. Zezwich from USF. So I'm going to kind of give an overview of behavior and neurocognitive aspect of Parkinson's disease. And as a clinician, I tend to be a little bit more grounded in the science, so my talk will kind of leak back to some of the more basic science, but hopefully not too much detail. But also, I'm going to interject some practical advice, hopefully there, a few little tips that can help with behavior and management of Parkinson's. So here we go. So this is kind of the overview of my talk. I'm going to give a little introduction to Roskamp, although there's already a pretty good job already done, so I'll just show it a little more with pictures. I'm going to get into a little bit of the brief pathology of Parkinson's disease. I'm sure many people here have seen some of those slides or some of those pictures, but just little reminders that may cue us as I go through the talk. And then this is a little bit of a more, not controversial, but I'm going to talk about personalities of Parkinson's and actually pre-morbid, meaning before people develop Parkinson's disease, there's some certain particular personality associated, and how does that tell us or maybe give us some insight on management down the road. And then talk about cognition, and I'm going to frame cognition. How do we as neurologists and neuropsychiatrists or neuropsychologists think about memory, thinking, language, and then how do we assess it? And then get a little bit into the driving, and then how Parkinson's changes with time, and then characterize Parkinson's dementia, and then also talk about the crossover, Parkinson's with diseases like Alzheimer's, as well as Lewy body dementia, and again, kicking back to pathology, and then some of the treatment and management. So that's kind of an overview of the talk. This was a slide about Roskamp Institute, really talking about I'd like to always plug Fiona Crawford and Mike Mullen. Dr. Mullen and Crawford were credited for discovering the sweetest mutation of Alzheimer's disease. And I'm going to just talk a tiny bit about genetics later on in the talk, so how important genetics may also play into these diseases. And there's also this thing called Open University. So we have PhD students rotating at Roskamp Institute, so we get to talk about basic science on Friday afternoons, which is one of my favorite things to do, actually. And so it's a really neat integration of, it's almost like it is a university feel right here at Roskamp. And then the overview, my picture of describing it, I usually have a pointer, but we have two slides, so I can't point at both of them. But we have the basic science, which really is kind of the larger portion. That's the PhDs kind of working in the back, looking at how things work kind of in a petri dish or perhaps an animal model. Then the pharmaceutical trials, which is something I participate in, where we have people that are in phase 2 or phase 3 clinical trials, and then the patient care, which is where it kind of all ties together. So that's kind of a general overview. It's a public nonprofit. It's up there north of University near the airport, kind of on the border of Bradenton and Sarasota. So now for the talk. So this general picture kind of shows the neuropathology behind Parkinson's disease. This is even an older slide. Things really haven't changed in the major aspects of the neuropathology. And on the left, you'll see on the top, you'll see a picture of a brainstem. The brainstem, that's pretty deep down. So that's just above the spinal cord, below the brain. And you'll see those two kind of dark lines kind of in that shape, kind of angled. That's the substantia nigra, and that is very important in producing dopamine. So people who have Parkinson's, they're short on dopamine, and you can see the slide below where those dark lines are not there. And the slide in the middle shows some dark spots. So those are the cells that are producing dopamine, and you can see with the Parkinson's patients below, there's kind of an absence or a reduction of those cells. So that's why we're always trying to give medications like Cinebet, carbidopa, levodopa, Mirapex. These are medications that are trying to provide dopamine because not enough of it's being made, because those cells have been lost. One of the culprits on the final slide, on the final panel on the right, you'll see an arrow pointing to a Lewy body. And a Lewy body is filled with this material called alpha-synuclein. And alpha-synuclein is this bad protein that seems to be causing trouble, leading to these Lewy bodies, which leads to the overall picture. This is a very generalized picture, but it's very analogous to also Alzheimer's dementia. Here in Alzheimer's, we have a protein called amyloid, and it accumulates in different parts of the brain, and it also causes neurodegeneration. So people are going after alpha-synuclein just like they're going after amyloid. So that's the general pathology behind the story. And we're all familiar here with more of the motor problems, the difficulty with walking and balance and stiffness. I'm going to get more into the neuropsychiatric, the cognitive impairment that is present, kind of the slowness of thought, and then sometimes the psychosis that sometimes comes about over time. I'm going to talk about some ways of intervening, and then REM behavior disorder, as well as a little bit about fatigue. But I'm hoping fatigue is something that Dr. Zezwich, she's going to talk about holistic approaches to Parkinson's. I'm actually interested in hearing some of her approaches, so I'm looking forward to that talk, but I'm hoping she has also some advice on fatigue. So this again gets back to the picture of the progression. So I showed you those pictures kind of low in the brainstem. So in the very beginning, at the very bottom, you see that pinkish aspect on the very bottom left brain. That's kind of the disease starting. And that's when people may have some premotor symptoms, constipation, being lightheaded or dizzy, and then it progresses up into the full brain over time in certain regions in particular. So this is kind of overall how we see it progress, but there is some question of perhaps there are some things that are going on even before the disease, and that's kind of what I'm going to get on about personality. Also, just a quick note, there's a small arrow on the left panel pointing to the olfactory bulb. Sometimes people present before even having the disease, they'll have a loss of smell, and that can be a warning that Parkinson's may be starting down the line. So, is there a personality associated with Parkinson's disease? And this may get a little more personal because I've seen some things that I hear from people, kind of the type of work they do, the type of maybe personality before they develop the Parkinson's. And personality is harder to quantify. If someone breaks an arm, you can look at an x-ray and say it's broken, it's a severe break or minor break, whereas personality gets a little bit more challenging. So I'll just ask you to think about people that you know, a spouse or a loved one, or if you're caregivers for people, if you thought back to personality of someone with Parkinson's, if there tended to be a little more of a cautious, a little more rigid kind of personality, but very industrious, kind of doing things, maybe an accountant or financial, very orderly, and then a little less impulsive. Those type of personalities, in the long run, you really need to be more careful, require predictable routines that keep people engaged. As Parkinson's kind of ensues, we want to make sure that people are still very engaged in the process, in process of life. So when people looked at personalities, this is the two main features that seem to be before disease ensued. They tended to be a little more of a low novelty seeker. So we measure rigidity with people with Parkinson's. They tend to be a little stiffer, but can there be a little more of a focused, rigid, but industrious type of personality that precedes the disease? So some have looked at the substrates for this, and GABA, which is also associated with dopamine. This gets a little more of the basic science. Some have attributed it to a relationship with that, as well as this certain region of the brain, the frontal subcortical region. So even though we think of the diseases starting kind of from the brainstem moving upward, and that's how it progresses, there could actually be some features that are already present before we even see the disease present. Okay, so cognition. Again, I see people with, I'm a general neurologist, so I have people that come in, they present with memory complaints. Maybe they're forgetting words, or they're forgetting events, or they're having a hard time planning. So we have to kind of assess that. And sometimes when we talk with people, we actually find that they may have Parkinson's, or they may have Lewy body, and they may be presenting with some memory complaints, but they actually have a general neurodegenerative disease besides Alzheimer's. But this picture is kind of how we think about it. So that shows a side view of the brain, okay? So that's what that picture shows. And the number one area is more the temporal lobe. So these are in here, kind of in medial or inside towards the ear. That's where things like memory, if I give you some things to remember, if I ask you to remember pickle, white, and stove, and say a few minutes later, do you remember those 3 words? It requires that hippocampus, which is in the temporal lobe, to store that information. Language is a little more the parietal lobe, and then attention and judgment, trying to make those decisions about, for example, coming here today, putting it on your calendar, making the plans to come here. That is more of a frontal lobe and a judgment area, and then the visual spatial is more the back of the brain. So as a neurologist and neuropsychologist, when they're assessing someone's cognition, these are the main domains that we think about. And if everything's working fine, then you do well with activities of daily living. And there are kind of basic activities of daily living. Those are more, you know, eating, restroom, walking, those type of things. But the more instrumental are more kind of like keeping up with finances, keeping up with your calendar, talking about current events. So if everything's functioning well, we're now going to look at when things decline. So a typical, but not everything's typical, a typical pattern of Parkinson's disease. So if someone has normal cognition, but now there's something slipping, when a neuropsychologist measures these different regions, the executive or that planning stage seems to be the slower or the area that doesn't seem to be doing as well. And then sometimes that visual spatial is the other area. So again, that goes back to that overall diagram of how this disease progresses. As we get into the middle and right panel, we start getting into that, you see that arrow kind of going forward, we're getting into that front subcortical area. So that's why those areas are not doing as well. And when this is one study where they measured people in the clinic, a newly diagnosed Parkinson's patient. If they spent 3 hours or 5 hours doing a detailed memory test, about 20% of those people have mild cognitive impairment. They do have some cognitive impairment. They can still participate, do a lot of activities. They just may need some support or some, you know, keeping notes and records and some other things to suggest. And this is, like I was going back to, maybe some tips or advice for caregivers or spouses, really kind of being aware that some of the planning may take a little bit longer. So anticipate that. Coming to an event like this, you may have spent a little extra time, got up a little earlier, and then just make that extra preparation to get here. Because if you try to go at the same speed that you were going before, that's just going to lead to, you know, a struggle. It's going to be a challenge, and it doesn't work well. So kind of making sure that you're planning ahead, but that's part of this process. So you're just kind of adjusting to that process. If those frontal circuits aren't working as well, also things like maybe we're coming up here to tax season, so you're getting paperwork together. Some of that planning someone is still doing, they still want to be. Remember, they're industrious people, they want to be engaged, they want to participate. Give them a little bit more time, start the process a little bit earlier, and do it. That people are still very capable of doing that, and keeping engaged is critical. It's critical for mood and anxiety and depression, and actually I think some of that stuff feeds back to the disease itself. So preparing and anticipating this change will reduce some of the stress that comes with the disease for both the patient and the family. So I think that's very important to keep engaged. So this is a hot topic, kind of a dangerous topic to discuss, and I've been into some difficult office visits in the past over this topic. I'm sure I've lost some patients, for sure, bringing up this topic. So the clinical curl is actually on the bottom there, is you need to talk about this. We as physicians, clinicians, nurses, anybody working with patients with Parkinson's and family, just have this discussion early on. At some point, driving may become a little more challenging, and we have to be aware of it. But it's one of those things that's a huge independence factor. I mean, there's plenty of research showing you, if you take a car away from someone, they can become depressed. It's a real, honest-to-goodness thing that happened. So if we start thinking about it and preparing for it ahead of time, then it's a little bit more of a softer landing, and it's just a difficult topic overall. I have this line in here, and these are just the studies that are out there. 11 studies found that drivers with Parkinson's, and these are not people with dementia, these are just good Parkinson's patients, they don't drive as well. Their performance overall as healthy controls, okay? So that doesn't mean they're not safe. I mean, I think, you know, some kids, 17, 18-year-olds, they don't drive as well either. It's a different type of not driving well. So the goal is really to have a reliable and predictable way of handling this. And unfortunately, there's no measurement. You know, for example, with Alzheimer's disease, we do this mini mental status exam, and it's a score from 0 to 30. We can't just say, well, there's a number. If they get above that, they can drive. Or below that, they can't drive. There's a whole bunch of factors involved. And it's much easier if the patient and family kind of step back and say, look, I'm not comfortable driving at this point. I've thought about it. I'm a little nervous driving, and I don't want to do it anymore. I don't want to hurt myself or hurt somebody else. And those are some of the best things. If you really counsel early and discuss it early, it's usually, I have patients that say, look, I don't want to drive. And so I think that is the best way for it to come about. Otherwise, sometimes you get into situations where you have to order a driving evaluation, and SMH has a driving evaluation. So they put you through, some cognitive testing, then you move on to a computer test, and if you're doing well enough, you then move to actually getting out and drive. So then we can have kind of a third party objectively evaluate driving. So it's a sensitive topic. I advise people just to bring it up early, and I think then everyone can accommodate. And thinking about, you know, where you're going to live, long-term decisions, you'd rather not be way out in the country if you're going to have to make a lot of trips. You'd rather be kind of closer if you're going to want to come to events like this, come and get education. But those are very personal choices. So, and everyone has to think about it in their own way. So anxiety and depression, I'm not going to get too much into this, but it certainly comes up. It comes up with chronic disease, all types of chronic disease. It comes up somewhat with the aging process. So kind of don't let it go away, but sometimes it can also be a precursor. People before developing Parkinson's, actually it seems like there's a little bit of anxiety that creeps up. We're not sure exactly why biologically that happens. And therapy is always the first choice before medications, but sometimes medications have to be added. We know in Alzheimer's disease, there's actually, I talked about that evil protein amyloid, and in Parkinson's we have alpha-synuclein, so the amyloid protein actually can be lowered or improved with a mild SSRI. So there's some, SSRI is kind of a standard antidepressant, so there's a biological reason you can actually potentially help the disease as well. So now we have this person who's moved from mild cognitive impairment to now dementia. And I know the most common question whenever I give a talk is about what is dementia, what is Alzheimer's dementia. I'm just showing you Alzheimer's first as opposed to Parkinson's. And those two top lines, usually Alzheimer's dementia is memory, like they repeat things over and over again, and then language, have a harder time finding words. So that's the typical pattern, and then they've lost that level of function. They used to take care of the finances, be able to find their doctor's office, they do the planning, and now that functional decline has moved them from, well, a few crutches helped, but now those aren't working anymore, so you've had what they call a functional decline. It's a lot harder to objectively define that, meaning just like my example of the broken bone, someone has a broken bone, you can see an x-ray and it's objectively broken, you know it's broken, whereas functional decline, it's really questions. We ask the family, okay, are they driving as well as they used to? Are they taking care of the finances well? Can they keep up with current affairs? And if they score poorly on a set of those, then that's kind of a functional decline. And so their instrumental activities of daily living have declined. So that's where we move to dementia. And then Parkinson's tends to have a little different pattern. They're not usually the people that are repeating things. They're not asking the same question over and over again. They're more the person that may be having a little more trouble finding their car, or that navigation with driving, that visual spatial type of stuff, or slowness of planning and then kind of making mistakes with planning. So again, that's that executive function. My neuropsychologist would do a better job of describing some of those subtle things, but those are some of the things that we see in the office. And the epidemiology, kind of the numbers of people with Parkinson's, the overall lifetime risk of a Parkinson's patient of developing dementia is 30 to 80%, and it increases with age. This is kind of going back, I have to give you a little research study. So this is one example, a Danish study where they tracked 224 people in their clinic from when they first came into the clinic. 28% of them had some dementia at baseline, and then over 8 years, it went up to 78%. So 8 years, I mean, that's a fairly long time. So there is time to intervene. There is time to kind of take action, prevent that or slow it down. Some of the things that are a little more risky are if people are having hallucinations. Typically, these are visual. And if you have a type of Parkinson's that doesn't really have tremor, it tends to be just the stiffness and slowness and not the tremor. Or maybe a little mix of the tremor, but not as much of tremor. Those tend to be the people that progress or have more dementia earlier. And then kind of just a recap of Parkinson's, again, executive functioning, visual, spatial, then later memory and language. And again, I try to think about it from the brain perspective. You don't necessarily have to think about it, but hopefully some of those visuals will help bring it in a little bit. And these are some just little subtleties, again, in the pathology. So that first one, the basal forebrain, those cholinergic, I know people have heard of anticholinergic, bad. Acetylcholinesterase inhibitors, more acetylcholine, that may be good, and it's because of this neurodegeneration of this part of the brain. So what do we use? We use a medicine like Exelon or Aricept. It provides more acetylcholine because there's not enough of it there. We don't like people to be on anticholinergic medicines. People have urinary urgency. They take drugs like oxybutynin, Detrol, these type of things. We kind of prefer them not to have to use them, but sometimes they have to. Those work against acetylcholine. And then we talked about the dopamine, and you saw that picture of the arrows as it's progressed, those dopamine that project up to the subcortical, that's leading a little more trouble with executive functioning. And then the Lewy bodies, which have that alpha-synuclein in it, those are things that can cause trouble. And then there's also Alzheimer's pathology in some people with Parkinson's disease. So, and that's not a surprise if there's cognitive problems. And this is just a little slide, maybe a little more detail, talking about Parkinson's with mild cognitive impairment. There can be amyloid, that other bad protein in the brain, maybe not quite as the same level as as an Alzheimer's patient, but it's there. And the higher the level, or the more likely that person is going to have dementia or cognitive impairment. So in the animal models, it seems like those two proteins, alpha-synuclein and amyloid, seem to synergize in causing more trouble. So hopefully some of the medicines down the pipeline are going to go after these and effectively remove them. So I alluded to this. The one drug that is FDA approved for Parkinson's dementia is Exelon. There are a couple cousins people are probably familiar with, Aricept, which is also known as donepezil or Razidine. Those are some of the other cholinesterase inhibitors. They're all fairly similar. They come in different forms, patches. Exelon comes in a patch. That was the nice advantage because it's a slow release as opposed to a pill that kind of hits you all at once. They did try, I don't know if people here are familiar with Azilect or Rasagiline. That's a drug that helps promote more of that dopamine. We want to have more dopamine. They did try to see if that slowed progression of dementia, and unfortunately it did not work. Dr. Hauser up at USF and Dr. Zezwich is from USF. They were involved in that trial. There are trials ongoing with Alzheimer's going after amyloid, and so far we haven't had a good hit, but there's some information that it is moving. And then also there is a phase 2 trial at USF. It's usually for people kind of newly diagnosed with Parkinson's. Usually the phase 2 are the earlier studies, but they have a molecule that is going to grab onto alpha-synuclein and try to pull it out. So they're kind of following the same path that they've done with Alzheimer's research. They're going after the bad protein, trying to build antibodies that'll pull it out, and hopefully that can intervene or slow the progression of the disease. Okay, so this is again another advice for the caregivers. If there is a rapid change that you're seeing, and many people here may already know this, but I think it's just important, good advice to think about. Is there some infection? Is somebody dehydrated? Have you, is there urination? Is their urination now slowing? Is there something different about it? Is their urine more dark or cloudy? Are they complaining of pain with it? Are they coughing and having an infection? That can be a sign that those things will rapidly change someone's behavior. People can now, they weren't hallucinating, and now suddenly they're hallucinating, seeing things that aren't there, or they're very confused. Maybe they haven't been getting enough input, they've been not feeling well in the past couple days, so then they're not drinking their fluids. So those are things that caregivers, spouses, family members can kind of assess, and that helps us as clinicians knowing that beforehand. When you call in to talk to your doctor, having that information on hand is important. And then there's been a new medication, maybe he hasn't been sleeping well, so you put him on Tylenol PM, something that has Benadryl in it, or maybe they just saw their primary care and were put on an anticholinergic because they've been having urinary urgency, and that could lead to a pretty quick change in some patients. So think about those things. And then the Parkinson's medicines themselves. This is our challenge as clinicians. As the disease progresses, we're trying to give, as someone's declining, we're trying to give them medicines to bring them up, but eventually the medicines don't work as well and give more side effects. So now we're taking somebody and giving them more and more dopamine, and dopamine, well, we talked about that low impulsivity, can actually increase impulsivity. So next thing you know, they're online and they're gambling, or they're looking at things they shouldn't be looking at, or they're falling asleep suddenly while driving. These are very real side effects or behavior changes that can come from giving someone too much dopamine, and the dopamine agonists are most well known for that. Mirapex, Requip, and Neuro. Those are the commonly used dopamine agonists. So maybe that was started, and maybe you're seeing some of these changes in your spouse or loved one, and that's something to go, okay, now I'm seeing this connection, so we're going to act on it. I have seen some people fall asleep just spontaneously during my talk. I mean, sure. But more seriously, during driving is probably the most dangerous, but these are things that are real factors or side effects of these medications. And then the last one, I'm sure most people have heard this spiel before, but caregivers, please, get your rest, use some behavioral things, kind of what I talked about before. Give people a little more time, recognize some of the triggers. Some people kind of antagonize each other a little bit. Sometimes I get into almost like marriage counseling when I'm visiting with couples. You just have to bring these things up and talk about them. And then modifying the environment, lighting, the logistics of getting from your car to your house, within your house, making sure things are clear and easy to move around. And then for the caregivers, making sure you're bringing in support. If family or friends offer support, take advantage of that. Get that support. And sometimes it does require hiring support, and people resist that as well. I know it's financial, it's a logistical thing, but the caregiver is the one that could end up in the hospital, unfortunately. And so we always, and you'll hear that recurrent theme if you haven't heard that before, we're trying to protect the caregiver so they can keep the patient as healthy as they can be. So the caregiver has to really tend to their own health. So I'm going to segue a little bit to Lewy body dementia. One of my earlier slides showed that Lewy body, right? So that's thing that causes Parkinson's. So what is this thing, Lewy body dementia? I think of them on the same, they're just on a spectrum, so there's some overlap, and I'll show you a picture that'll really emphasize that overlap. But the one key thing that distinguishes is if someone has Parkinson's, they've had it for 7 or 8 years, they're doing pretty well cognitively, maybe they have some mild cognitive impairment, they can keep some notes and things, but then they start having more trouble with language and memory, they're moving into dementia. That's Parkinson's dementia. Whereas Lewy body dementia is someone presents within a year of having some kind of maybe Parkinson-like features, but they move right into dementia. And one thing sometimes they report are these visual hallucinations, and we'll see it with both diseases. Little people, little animals, they'll be very real to them. Some people here maybe even have experienced something like that. And they can be friendly or not a problem, and some can be very scary. It's very interesting to hear all those experiences from patients, but they can be a sign that this disease is more of a Lewy body type picture, but we also do see it in Parkinson's dementia. So again, that's why I think of them as an overlap. There's also this kind of fluctuations. People have some really good days or even a week, and then they can have this really down, less cognitive well time. That's one of the real characteristics of Lewy body as well, and those well-formed visual hallucinations. And of course, they have to have Parkinson's. I don't want you to read this slide, but this slide shows kind of the one column has Parkinson's dementia, and the other column has Lewy body dementia. And there's quite a bit of overlap there. So, and this pictorially gives you an idea. I don't know if people have heard of DAT scan. Dopamine transport. It's kind of a neat way of measuring someone's dopamine activity in their brain. You can see on the left side a healthy control, this kind of comma shape area of activity, so that's good. You can see an Alzheimer's patient below there still kind of has that comma shape, but the Parkinson's and Lewy body, there's just that little kind of round, that's the caudate part of the brain. That's where, again, that dopamine is being moved around. So that part of the brain is still active, but the other part, the bottom comma part, is no longer active. But you can see how Parkinson's and Lewy body look fairly similar. Are we experiencing technical difficulties? No? Okay, sorry. I thought I see the picture there. Okay, so I promised a brief talk about genetics. So this is genetics in Lewy body dementia, and this is really fresh off the press. I think maybe it was published maybe 2 weeks ago, I'd say. So GWAS, I know it's a big acronym, Genome-Wide Associated Study. So I'm going to give you a kind of a simple breakdown of that. So they took a lot of people with Lewy body dementia and looked at their genetics, and they said, what's similar to all these people? What are the genes that seem fairly similar or consistently similar? And this is, like I said, a large number of people. And Lewy body is hard to make the diagnosis. The most common diagnosis that we as clinicians, we miss it. We miss it on a regular basis. It kind of is insidious in the way it presents, and it can be a challenge. The DAT scan has helped us, but these people were proven to be diagnosed with Lewy body based on pathology. So eventually, as over years went by, they had passed on, and then a diagnosis was made by pathology. But what were the genes that they found common in these people? Well, they found the ApoE gene. That's that first one on the list. ApoE is a gene that's involved also in Alzheimer's dementia. Well, that's not a surprise. You have a disease with dementia, and you have Lewy body dementia. ApoE is also a genetics involved in Alzheimer's and Lewy body. SNCA, so they try to play tricks on us on how they label these things. What is SNCA? Well, that's the gene that's responsible for making alpha-synuclein. So that's another one. That's not a surprise. And then there's also GBA, which is associated with Parkinson's disease. And the newer one is the CNT1. I don't know as much about that, but it's near the LRRK2 gene, and maybe some people have heard about LRRK2 gene. That's one that is certainly associated with Parkinson's disease. So again, the genetics of Lewy body dementia are clearly Parkinson-like and also Alzheimer's-like or dementia-like. So that seems to make sense. And hopefully these will give more clues for interventions down the line. Hopefully these will give more avenues to approach. But I'm already happy to see that they're going after alpha-synuclein in phase 2 trials. So that's in people. It's not something that just makes the news. You'll hear things over and over. Some animal they cured of this disease. Well, that doesn't necessarily mean it's going to work in human. At least now it's being tested in humans. So that's the good thing, that it's moved that far. A little bit back to the behavioral disturbance and caregiver burnout. The little graph, the bottom, I'm not sure what color that would be, the darkish purple, and then the green. That bottom half are caregivers that are between 55 and I think as high as they go there. So that's the majority of caregivers, and they tend to burn out, and they're more likely to burn out when we start getting into the phase of Parkinson's, which is much more challenging, where people are having delusions and hallucinations, and they're having more agitation and aggression. And these are the things that are, strongly correlated with caregiver burnout. And the definition of Parkinson's psychosis, there's a list. This is kind of a clinical diagnosis. You have to have Parkinson's disease. You also have to have either a hallucination. So hallucination we usually think of as visual. I described those before, something you see. Or you can have a delusion. A delusion is like a false belief. So you thought your son was over yesterday, you're convinced of it, or you think someone may be outside knocking on the doors trying to break in. These are delusions, not necessarily a hallucination. An illusion is maybe you look under the chair and you kind of think it, because of the shadowing, it looks like a dog. So it's kind of, the vision is just kind of a little confused about what they're seeing. Or this other thing people do have, it's not maybe as common, a false sense of presence. And this isn't like a religious thing. This is more of a, that you think something else is in the room and you're not sure what it is. It's kind of scary to you. So those are features of what can happen with Parkinson's psychosis. And if it recurs over a month, then for sure it is Parkinson's. And again, these people don't have to have dementia. They don't have to have mild cognitive impairment. It can happen in a Parkinson's patient without that. And it can't be explained by something else, like an infection or an anticholinergic or an adjustment in medicine, too much dopamine. So we're usually busy when we see this. We're trying to adjust, minimize the medications, adjust those, look for infection, and if it's still persisting, then we're thinking it's psychosis. Psychosis, unfortunately, is a little more of a poor prognosis, usually worsens with time, and there's even a mortality associated with it. But 50% eventually will develop Parkinson's, psychosis, but that means 50% won't, okay? So this isn't, not everybody with Parkinson's will develop this, but it's something to keep an eye on because it can, again, that's when you really, as a caregiver, need to be a little more aware, bring a little more help, because it may be a little more challenging. So there are modifiable and non-modifiable. So the non-modifiable is the age, and the more severe of the disease, and then other comorbidities. And then the modifiable are, like we talked about, medications to avoid, the lighting in the room, the environment, and the time of day. Some people, go out for dinner, tend to go out a little bit earlier because maybe later it's not as good. Trying to time things at optimal time of day so that psychosis doesn't become more of a problem. And usually in the evening or nighttime, it can be more of a challenge. There is a medication, I'll plug the one medication here, Newplaza. I believe they're also one of the sponsors here. This is one of the only drugs approved for Parkinson's psychosis, and it acts on serotonin in kind of a novel way. Serotonin is a receptor that it's also involved with depression. There's some side effects, potential side effects there. All of the drugs that we use for psychosis and Parkinson's are going to have some type of black box warning. Unfortunately, they've been associated, they did like large studies looking at thousands and thousands of people that take antipsychotics. These are drugs like Seroquel and Risperidone, and those drugs potentially can widen the QT, which is a feature of the EKG, and you're taking somebody who already may be a little bit fragile and putting them on a medication, and that could potentially increase the risk of them having a cardiac event. So we don't want to use these medicines. I assure you as clinicians, we don't want to use them. There gets to a point where sometimes we have to use them. Some may use them a little more quickly, some may use them a little more slowly. We try to use medications that are a little more safe, but to be honest with you, common SSRIs like Lexapro and Celexa, they also widen the QT in theory. So there's the risk is everywhere when you start looking in details. So we try to be cautious, but some of the medicines like Seroquel, which is better on the movement, and this again gets to that dopamine story, we want to block some of the dopamine that's causing the thoughts, but we don't want to block the dopamine that's making somebody move. So we're always trying to balance those two things, reduce some dopamine medicines to reduce the psychosis. So this drug kind of has a different mechanism which gives us an advantage because it's not acting on the dopamine receptor. So that's the nice thing about using a drug like this. So if people are trouble with Parkinson's psychosis, they should discuss that with their clinician as well. I was just going to quick allude to, I don't know how I'm doing on time here, but I'm almost getting close to the end here. So REM behavior disorder, this is one of those things that people, it's actually the spouse that'll notice it. People may swing or punch or kick at night. It can be dangerous for a spouse. I've seen spouses with black eyes from this. And there is a drug, we use Klonopin or clonazepam. It's a Valium-like medication. It's very effective, but it can make people more sleepy. But that's one of the drugs we commonly use. Sometimes REM behavior disorder can come before the disease is obvious. So if we see a patient with dizziness and REM behavior disorder, we should start thinking in 5 years from now they may develop Parkinson's disease. And then fatigue. Sleep, unfortunately for a Parkinson's patient, is not good, not good. If you measure it, you look at people sleep overnight, you measure kind of how their brain activity is doing and how they're sleeping. Usually we're trying to find a diagnosis of sleep apnea, dysregulated breathing at night, but sleep tends to fragment also as we age. We don't sleep that nice. We have cycles where we go into a light sleep, deeper sleep, then REM sleep, and we kind of go back up to a light sleep, deep sleep, REM sleep. Those are like normal sleep cycles. And if you have good consolidated sleep, you can remember what you did the day before, you can feel well rested when you wake up. But with age, we tend to have more fragmented, or maybe there's pain, or the medication is affecting your dreams. Some of these people can have more dreams with dopamine, and so all this leads to a challenge with sleep. And sometimes people have to sleep twice. They have a shorter sleep overnight, maybe they have 4 or 5, 6 hours, and then they may have an hour-and-a-half nap through the day. You really have to work with your clinician on trying to find a balance and a way of just trying to make sure you get enough sleep, and it may even be broken up in 2 different times a day. Of course, we're going to try to remove offending medications, but sometimes these medicines we have to use. All of the Parkinson's medicines list fatigue. They all list sleepiness as a potential side effect, unfortunately. The dopamine agonists tend to be a little worse when it comes to that. And then we'll look at labs, is someone thyroid being off, or are they infected? And then a sleep evaluation to make sure somebody doesn't have sleep apnea. And then off-label, people have used Provigil or Nuvigil. Those are medications used for sleep apnea. So again, anticipate, this is kind of wrapping up, anticipate future challenges and prepare. Stay connected with family, friends, stay educated. You're all here, so you're trying to seek education. You're at a great foundation, the Neuro Challenge group, so you're staying connected. I think that's incredibly important, and that's the support group. You learn from others on a regular basis, little tips that we as clinicians are not as good at giving are much better provided by someone else who has experienced this on a day-to-day basis. This is a picture, something I picked up from one of the Neuro Challenge events. I think it's an awesome picture, a very interesting concept. Someone with Parkinson's and their view, it was painted by a Parkinson's patient. And then, in the meantime, this applies to everybody here, and I'm sure Dr. Z will focus on some of these. Remain socially engaged and active. This is good for the brain for all people. Mental activity, read, keep up on information, a mind-healthy diet, and physical activity. You all have heard over and over how important physical activity is for Parkinson's as well as Alzheimer's. Whatever you can do to remain physically active, that's great for the brain. And also get some rest. Don't wake up early for talks at 9 a.m. So, I'm sorry. And then clinical trials, a quick plug. It may not apply to people here, but we are looking for people who were veterans of the Gulf War that actually don't have Gulf War illness, that are healthy and can come in for a morning to give a sample of blood. We're looking at inflammatory markers that could affect the brain. And then also people with a mild to moderate traumatic brain injury between age 18 and 55. If people are interested at being kind of followed, having their memory followed over a 3-year period, we're looking at how traumatic brain injury, which is actually a big risk factor for Parkinson's disease, we're looking at it in Alzheimer's, but hopefully some of the information gained from that will also apply to Parkinson's disease. So I think that is it. And I don't think I take questions, and I don't think I take questions, right? We're good.
Thank you very much, Dr. Keegan. That was very informative.
All right, I am very happy today to introduce to you Dr. Teresa Zeschewitz. Dr. Zeschewitz is a board-certified movement disorder specialist, professor of neurology at the University of South Florida, Tampa, and director of the USF Francis J. Zeschewitz Parkinson Foundation and the USF Ataxia Research Center. She is a fellow of the American Academy of Neurology, as well as receiving her BS from St. Peter's College in Jersey City, New Jersey, and her MD from the University of Medicine and Dentistry of Newark, New Jersey, and did her residency in neurology in the State University of New York, Brooklyn, and her fellowship in movement disorders at USF. That's a lot of education, Dr. Zeschewitz. Woo! She has written several books and has authored over 160 peer-reviewed papers. Please welcome to the stage Dr. Teresa Zeschewitz.
Okay, high heels, tight skirt, not good. Hi, everyone. Great to be here. And I see some familiar faces, and I just want to thank the Neuro Challenge organization for inviting me here today. I'm not only here as a doctor, a Parkinson's disease physician for 25 years, but I'm also the daughter of a Parkinson's disease patient. My mom suffered with Parkinson's, thank you, for 20 years, and she lived with us. So you really don't know how, well, maybe you do, how lucky you are to have this Neuro Challenge Foundation down here. I know that with my mom, she needed to be within 20 minutes of her doctor. And you've got so many good things happening here. So thank you again to Neuro Challenge and for what you do for our wonderful patients. Okay, so today we're going to be talking about holistic therapy. So as you know, I'm a conventional physician, neurologist. I deal with medications. But one of the common questions I get from patients are, what about holistic therapy? What can I do to help my disease with non-traditional medications? So I thought we would go through that today and then go through some of them from A to Z and see if maybe these are some medications or therapies that you can use. So what is holistic medicine? Holistic medicine is a form of healing that considers the whole person, body, mind, and spirit, and your emotions. They want to help you get optimal health and wellness. And it can deal with non-traditional therapy. So according to holistic medicine, one can achieve optimal health. The primary goal, of course, right, is optimal health by gaining a proper balance in life. So the whole person, as you know, is made up of interdependent parts. If one part is not working properly, the other parts will be affected, right? If your back hurts you, do you feel well? No. If you're depressed, are you going to handle life well? No. So you need a balance in your life. And we want to look at your physical, but also your emotional and your spiritual parts of your overall health. And you know that Parkinson's disease, as I know, affects your whole body. Okay, it causes depression, it causes anxiety, it causes balance, it causes constipation. So it's vitally important to maintain a whole balance. And that includes body, mind, and spirit. So holistic medicine reviews all the potential factors that could be interfering with you not having that great quality of life. And this includes your diet, your sleep habits, and your stress level. And the treatment plan may include drugs that we always use, but it also may include lifestyle modifications to prevent symptoms from reoccurring. Okay, so patient education is very important. Diet, exercise, relationship, and spiritual counseling. We're going to go through some of the complementary and alternative therapies. This includes acupuncture and chiropractic care, massage therapy. Okay. I was thinking when I looked at this slide, when we have slides of conventional drugs for Parkinson's, we never see pretty flowers with them. But holistic therapy sometimes comes from plants, which is probably why we see the plants and the flowers. So an increasing number of patients are looking to supplement their standard levodopa and other medications with holistic therapy. These include natural products such as herbs, vitamins, minerals, probiotics, as well as mind and body practices such as Tai Chi, yoga, relaxation techniques, or even alternative therapies such as Chinese therapy or Ayurvedic medication. Okay. When we talk about complementary medicine isn't really the term anymore. They more talk about alternative and integrative. Alternative means you're choosing an alternate to the normal medications that a neurologist like we would give you. But integrative means that we're going to integrate the medications that we give you with another holistic type of medication like herbs or minerals. Okay? All right. So here we go from A to Z. Acupuncture. Has anyone done acupuncture? Wow. No, okay. Awesome. So acupuncture has been used for many years in Asia, and it's been used to treat pain and skin disease, and it has inflammatory processes. When you use the acupuncture, did you use the bee venom with it? Sometimes they put bee venom in the needle, which can help the acupuncture. And it's developed on the premise that disease states are characterized by imbalances of flow of energy. So they insert needles along those points of the body to channel that energy. It is often looked at and talked about as complementary therapy for Parkinson's disease. 2 double-blind studies looked at the effect of acupuncture in Parkinson's disease, and they did not find any clear evidence of benefit for acupuncture in Parkinson. There were improvements in quality of life, there were some improvements in sleep, but not in the motor function. But again, if we're looking at your body as a whole, perhaps helping you sleep and helping you with pain would be beneficial. It just did not help the UPDRS, the clinical rating scale scores. Okay? Probably used to control pain, nausea, may help with sleep as well. You do need to go to a professional because they're using needles, you can get an infection. Okay, antioxidants. Anyone take antioxidants for Parkinson? This is a long story of antioxidant use in Parkinson's, and we always thought that antioxidants would be beneficial. You know, Parkinson's affects or is caused by oxidative damage or results in oxidative damage to the brain. So you would think that antioxidants would help. Unfortunately, many of the double-blind studies that have looked at antioxidants have not been beneficial. And it's interesting because we run an ataxia center out at USF for kids who die in their 30s called Friedreich's ataxia, and we give antioxidants to those kids too. It may be the type of antioxidant that is sold is not strong enough, or they're not giving it correctly. I mean, we use antioxidants that are about 10,000 times as powerful as the CoQ10 that you get over the counter, and they're catalytic. So I don't think it's that antioxidants just don't work. It may be that you need a different type of antioxidant. Okay? Now, you can use CoQ10 for heart health, of course, but we're just looking at the motor symptoms of Parkinson. How many of you are in any theater group? Oh, next year you've got to put on a production up here. Art theater, look, Hamilton. Do you know that active theater combines movement with stimulation of different sensory pathways, and that it actually has been shown to possibly help Parkinson's disease? You say, well, why is that? Well, when you get up in front of a stage, number one, you've got to remember what you're going to talk about. You've got to learn to project your voice. It gets you out of the house, and you're going to have interaction socially. So there are people who do theater to help them with Parkinson's disease. Ayurveda. Ayurveda is a traditional Indian medicine. This is thousands of years old. And they look at, again, the whole body, mind, and spirit. The concept is that health exists when you've got a balance of a few things. I hope I'm not mispronouncing the doshas, Vata, Pitta, and Kapha. Okay? But it's kind of the same thing as with holistic medicine, that you need a balance. I have a nurse with me, and she's a cardiology nurse, and she would love to go into Ayurveda. She thinks it really helps. The way this happens is that they have these Ayurveda resorts. I don't know what they cost. I'm sure it's not cheap. You go there, and they start the cleansing process. Has not been shown to be helpful yet in Parkinson's. Alexander technique. Has anyone done the Alexander technique? Alexander technique is interesting. It was named after its creator, Frederick Alexander, in an attempt to develop the ability to avoid unnecessary muscle tension by retraining your physical movement. So he believed that if you have poor habits in posture and movement, that was going to create tension. How many of you noticed that you're turning downward, or that you're beginning to stoop, right? So that's a habit also. And what they do is they look at you and teach you to raise yourself up and get rid of that habit, which really helps. You can't do the Alexander technique with a group, though. You'd have to find someone one-on-one to look at the way you're holding yourself, and then to try to, get away from that tension that you're doing, create better habits in walking. Okay, aromatherapy, this is when you go to a yoga. Do you do yoga? You do yoga? No. Now, yoga, when you go there, they do aromatherapy. Hasn't really been too helpful in Parkinson's, but it does cause a temporary calming effect. I would just say that if you're going to get into anything like oils or anything, to let your doctor know, because, you can have some interactions with some other medications. Biofeedback. Biofeedback can be very useful. Think of a situation right now, the last situation that you had that made you nervous. Are you thinking about it? What happened to your heart rate? Got fast, right? And what happened to you? Felt like you began to sweat and got a little nervous? You don't even realize that's happening to you, but it is. So what biofeedback does is it puts all sorts of leads on, and as you get nervous, it shows you that your heart rate's going up and that you're beginning to have hyperventilation. And in your mind, you recognize you're getting nervous and you feedback. So right now, in front of 500 people, you get a little anxious. You think about, wait a minute, I can feel my heart rate. I'm going to calm myself down. And I've found this to be very useful. There are two types of patients that I see. Some Parkinson patients come in very depressed. Some patients come in very anxious. I have patients who are so anxious they cannot sit in the chair in the exam room, okay? They have done very well with biofeedback, if you can look into a biofeedback program, okay? You are connected to electric sensors. You're going to receive information about what your body is doing, so that when you get that feeling that you're nervous, you calm yourself down. But the first thing is you've got to be aware that you're nervous or anxious, okay? Okay, chiropractic medicine. Anyone go to chiropractic medicine? Okay, founded near the end of the 1800s by an American healer named Daniel David Palmer. And what Daniel believed is that your spine influences all aspects of your health. So a chiropractor seeks to bring your bones, your joints, your muscles, and your nervous system into alignment and into balance. Most people use chiropractic for back and neck pain. It has been shown to significantly improve back pain. The problem is that when you do chiropractic work, about 50% of you may have some mild adverse events. So you need to be very careful if you've got back problems, because going to a chiropractor may, cause a few issues. It's not for someone with bone fractures or weak bones. Creatine. Creatine is a supplement that is used for bodybuilding. It's a dietary supplement. It helps performance. And minocycline is a second-generation antibiotic. Both of them were thought to possibly benefit Parkinson's. Unfortunately, in a large study by the Parkinsons study group, neither of them were really found to be effective. There was really no benefit from those. Diet. Diet is really important. So patients come in and they say to me, well, what kind of diet should I eat? I have Parkinson's now. Should I have a special diet or anything? Well, we say, well, we want you to have a regular diet. The problem is that if you eat a high-protein diet, that can interfere with levodopa. So I'm sure your doctors have told you that sometimes you have to put the protein off to nighttime and eat the carbohydrate more during the day, or at least space your medication out between the medication and the protein. Because levodopa is an amino acid. You eat a protein, the body doesn't know, well, should I take the amino acid from the food or should I take the levodopa? So that's a protein-sparing strategy, but we don't want you to become low on protein. You've got to have your minerals and your strength. You just may want to push the protein off till later on. I thought this was very interesting. This is the Mediterranean diet. So Mediterranean diet consists of olive oil and nuts and fish, and it's reported to enhance health status. Do you know that there's one meta-analysis of 12 cohort studies that followed people for 3 to 18 years, and they found that there was an overall reduction in the incidence of Parkinson's in patients who adhered to the Mediterranean diet. And as a daughter of a Parkinson's disease patient, I thought that was very interesting. There was no benefit once the patients had Parkinson's disease, but possibly some benefit, and I think this has to be looked into further. But you can understand that Parkinson's is due to oxidative stress, problems with inflammation. Mediterranean diet has a lot of extra virgin olive oil, and in particular, its phenols could be responsible for the beneficial effect on Parkinson's disease. I also thought this was interesting. In one meta-analysis, foods associated with a reduced rate of Parkinson included fresh vegetable, fresh fruit, nuts and seeds, as long as you don't have diverticulitis, 9 fried fish, olive oil, wine, coconut oil, fresh herbs, and spices. Foods associated with more rapid Parkinson's include canned fruits and vegetables, soda, diet and non-diet, which I love, fried foods, beef, ice cream, yogurt, and cheese. Sorry. So, I don't, listen, this was one meta-analysis. Yogurt's good for you. Cheese is good for you. We love beef. Soda probably you shouldn't be doing anyway. But, I went back to my youth, and I remember, maybe I'm dating myself, but don't you remember when we would have all the canned peaches and canned vegetables? Back in Jersey City, you didn't go to the market to get green beans. You opened a can. You opened a can of peaches or canned food. So, all this is saying is that go for the fresh stuff. Go for the fish. Go for the fresh fruits and vegetables. Go for the, if you can eat some nuts, go for that. And, hopefully, especially if you've got, children and you've got Parkinson's, you can pass it along. Coffee. Any coffee drinkers here? Clearly, published studies have identified coffee consumption as a negative risk factor for the development of Parkinson. Increasing coffee consumption has been recommended for Parkinson's patients with PD to a degree. You know, I mean, coffee can cause tachycardia, it can make you nauseated. We don't want you to be, you know, shaky. But a large number of epidemiological studies have clearly shown that there is an inverse relationship to coffee intake and the development of Parkinson's disease. And these are large studies, 8,000 men in Hawaii. One meta-analysis including 20 to 26 studies reported that the global risk of developing Parkinson's decreased by 31% and 25% in coffee drinkers, respectively, compared to non-coffee drinkers. Okay. There probably is a well-known mechanism of action. Caffeine antagonizes adenosine A2A receptors. These are located in D2 dopaminergic receptors in the striatum. You know that the striatum is a part of the brain that's affected by Parkinson's disease. Now, I hate to show this slide. Cigarette smoking actually has been shown to be a negative risk factor for Parkinson too. The problem is it's a strong positive risk factor for lung cancer, heart disease, and death. So I'd recommend you not go to cigarette smoking. Cannabis, I won't ask for any hands. Okay, I will. How many people, oh, you did it. How many people have gone to their doctor and have asked about cannabis for Parkinson? It's the number one question I get. And I have everything from 50 to 85-year-olds. The 85-year-olds will come in and go, don't think badly about me, but I've got a question for you. Like, I don't feel badly about you. We take it seriously. This is a plant substance used for centuries for recreational and medicinal purposes. You know, it contains 400 chemical compounds. It does influence the basal ganglia. That's part of the brain that's affected by Parkinson. And it's being studied for Parkinson's tremor and dyskinesia. We really don't have the answer on cannabis yet. I mean, that's the way I can summarize this slide. There is a small sample that looked at the clinical effects of cannabis in Parkinson's and found an improvement in motor symptoms, and that included on time, rigidity, and bradykinesia, and pain. Bad taste and drowsiness were the side effects. Okay? But there's another study in Israel that showed that patients were given cannabis and they put a lead on the patient's hand, and the tremor and the other symptoms didn't get better, but the patient felt better. Yeah. So I leave it at that. I mean, we can't prescribe it up at USF yet because you need a special license. There are prescribers up there, and I'm sure there are here. But I would just be careful, and, you know, we keep an open mind, though. I think the story has yet to be written about cannabis. Okay, coenzyme Q10, we went through this. What you get on your shelf at the supermarket, in the Publix, is not strong enough, it has not been shown to be effective in Parkinson. What you see on your shelf is 100 to 300 milligram. The studies went up to 2,400 milligram, and it did nothing. Now, it may be great for heart. I think it's great to take it, but not for Parkinson. Chinese herbs, these are also being tested for possible neuroprotective effects on Parkinson's disease. Okay, so if you don't want to do musical theater, how about dance? Anyone does dancing for Parkinson? Yeah? Okay. So dancing is actually a very good idea if you're able to do it. It's been associated with improved motor function and quality of life ratings, particularly the tango, because the tango, you have to go forward and I think backward. And it's the backward movement that's tough. You have to learn how to do the backward movement. Even Irish dance, anybody do Irish dance? Has been shown to be beneficial because of the cueing. They're going to get you up and try to do the dance, and you're going to learn how to cue. You're going to have to learn how to move your feet. And it, in one study, did demonstrate improvement in motor ability. So dance therapy, if it's not, you know, you don't fall down, can be enjoyable. It can be beneficial for improving gait and balance. Any fish oil takers here? Fish oil. Again, fish oil has omega-3 polyunsaturated fatty acids. It's going to lower the body's production of triglycerides, and triglycerides lead to coronary artery disease. What are the 3 common causes of death? Heart, stroke, and cancer. We can't forget those while we're trying to deal with this terrible disease. Fish oil can lower triglyceride levels in the blood, but it really hasn't been shown yet to improve the symptoms of Parkinson. Glutathione, same thing. Glutathione is an antioxidant. It's a powerful antioxidant. There is some thought that reduced glutathione levels occur in dopaminergic neurons, but a randomized clinical trial of 20 people did not show any benefit with glutathione. Again, it's only 20 people. It doesn't mean it doesn't work. It means that in that small study, it was a negative study. Tea. Who prefers tea rather than coffee? Well, I like tea. Green tea. Green tea is great. Green tea is a potential therapeutic agent. And there is a moderate decrease in Parkinson's disease risk for tea drinkers compared to non-tea drinkers. Ginseng. Ginseng has not been shown yet to be beneficial for Parkinson's, but it may be. Needs more double-blind trials. Herbs and botanicals, very interesting in Parkinson's, including melatonin. Melatonin is derived from tryptophan, produced in the pineal gland, and may be beneficial in terms of sleep for Parkinson's disease. Homeopathy. What homeopathy means, it was developed by Samuel Hahnemann. He was a German physician. And it works on the principle that an ailment can be cured by giving a person extremely diluted doses of a remedy that match the symptoms they have. They believe that this then stimulates the body's own defenses in trying to clear itself of an imbalance. So that's what homeopathy means. Kinesiology, developed by American chiropractor George Goodhart. It means the study of body movement. Kinesiology has been shown to improve movement. Basically, the therapist applies pressure to different parts of the body to identify trouble spots. Light therapy. How many Northerners here? Not as many. So up in New York, every day was gray. So this is more for, I think, the Northerners. When you're up there and every day is gray, some people get a little down, get a little depressed. So light therapy has been proposed as treatment for Parkinson's disease depression, seasonal depression. And one study studied bright light therapy for 15 days in the morning for 30 minutes each day, and it was hypothesized that light therapy would stabilize your circadian rhythm, especially those of you who are having problems sleeping. And in fact, light therapy was beneficial in improving the UPDRS scores. Magnet therapy. Anyone try magnet therapy? I think there was a period of time about 10 years ago where people would come in with magnets. Really hasn't been shown to help. You do? You use it, Parkinson's disease? He uses it. Oh, you have it on now. You know, there are many theories about how they work. There's not that much positive research. Not to say that it doesn't help other symptoms of Parkinson. Massage. Parkinson patients have reported transient improvement in stiffness and posture with massage. It can improve your posture, it can improve your slowness and stiffness, it can improve your self-confidence. When you get it though, it shouldn't hurt you. It shouldn't be painful massage. Meditation. Anybody meditate here? It's great. Meditation is free, it's low cost, and it's safe. It's coupled with the other things that you do, it can really help you. The mind is put in a restful alertness, and the body becomes relaxed. Your visualization, you form pictures in your mind. And mindfulness has been shown to be helpful. It can help tremor, slowness, mood, and Parkinson's. Again, low cost and safe. I think it's a reasonable addition to patients who can do this in their own homes. Milk thistle. I have a few patients who come in and take milk thistle for Parkinson's disease. Flowering herb may help Parkinson's, but we don't know yet. What milk thistle does is it helps your liver function. And because Parkinson's disease medications are metabolized through the liver, they're thinking that if you improve your liver function, the medications may be metabolized better. We really don't know. Mucunapurines. This is a substance that is found in fava beans. And I do have a few patients who eat fava beans because they want the natural dopamine. There is a measurable amount of dopamine in fava beans called mucunapurines. And preclinical studies show that there may be some neuroprotective role. The problem is you don't know how much mucunapurines or levodopa you're getting. There was one study that took the mucunapurines in different bottles from different brands, and they tried to detect how much dopamine was in the product. It ranged from 14% to 100%. So you just don't know what you're getting. But mucunapurines does have a levodopa effect. Why would you take this over levodopa? Well, there are areas of the world where people can't afford medication. And can mucunapurines or fava beans help these patients? There is also a study that is out now in Neurology Green Journal, which is our major journal in neurology. And it shows that the study looked at mucunapurines compared to conventional levodopa and actually found beneficial results from it. So I think that the story is yet to be written with mucunapurines. Music therapy, to go along with our art and theater. Music therapy will help you with the cues. You listen to music, it helps your limbic system. It's going to help your cue. It may even help you walk a little bit better. So I think music therapy is great. That baby loves it. Okay. There are studies that show that music therapy does have significant improvement in motor and quality of life measures. Okay. You've heard a lot about, I think, exercise today. I won't go through all this. I mean, by now, this is not even a complementary medicine. It is clear that exercise helps Parkinson's disease. I don't care if it's Qigong or Tai Chi or exercise, whatever. I mean, it's clearly exercise is beneficial for Parkinson's. It's going to increase endogenous dopamine levels. It's going to increase your cerebral blood flow. Helps dopamine handling, helps dopamine neurotransmission, may even improve neurotrophic factors. You should be exercising at least 3 days a week. I tell the patients 30 minutes a day, but if that's hard to do, start with 5 minutes. Increase every week by 5 minutes until you can get yourself up and exercising, okay? Probiotics. This is latest thing is a probiotics. These are bacteria that you take that can help the bacteria in your gut. So they're going to improve the bacteria that you have in your colon, and can this help? This study that's referenced on the slide shows that they took probiotics compared to placebo and that it helped constipation. You know, the question is, do probiotics help more than other constipation or anti-constipation remedies? I don't know. It's very interesting. There are studies that have looked at, this is gross, but they've looked at the feces of Parkinson patients and have looked at the colon. And it looks like Parkinson patients have more negative bacteria than non-Parkinson patients, which begs the question, if we introduce good bacteria to the colon, can that help you? And I think we'll be seeing more about this in the future. Okay, fermented milk containing multiple probiotic strains was superior to placebo in improving constipation. Psychotherapy, again, for depression and anxiety, or because you're just having a hard time with this disease, which is a bear. Psychotherapy can be very useful. Qigong, anyone do Qigong? Am I mispronouncing it? Qigong. Qigong is like Tai Chi, but what Qigong does is that you focus on energy more than in Tai Chi. So you like focus on an energy ball. Has not been studied in Parkinson's extensively, but I think it's more of a Tai Chi type thing. You combine the practice of motion and rest, but you also think about energy. And there's also some meditation with Qigong. Resveratrol is another flavonoid antioxidant, and this is present in vegetables, fruits, grains, roots, flowers, seeds, and most notably in red wine. Resveratrol has been reported to increase the level of manganese superoxide dismutase, which is shown to be beneficial in possibly in neurodegenerative disease. This is also being looked at in not only Parkinson's, but in also other mitochondrial diseases such as Friedreich's ataxia. Reflexology, this is based on the idea that areas of the feet match up to parts of the body. They see the foot as a miniature map of the body, has not yet been proved effective by Parkinson's. So I had a few people say, don't forget to talk about sexuality. And I said, I'm not talking, but I get a lot of questions about sexuality. This is an area of life that is definitely affected by Parkinson. And I get a lot of requests, we all do, for Viagra, Cialis, and some of those, aids. And I think that it's important for you to bring this up with your provider. It's something we hear about constantly, not only in men, but in women too. Spirituality, important in Parkinson. 90% of patients that we have in the clinic have sleep problems. Multifactorial can be anything from you don't have enough medication before you go to sleep, to I have to get up 5 times to go to the bathroom, to I want to work on the computer. It's really a multifactorial issue, and I think it's also important to bring this up to your physician. Speech, we had the lovely ladies talk about the LSVT. Parkinson's disease begins in the swallow center. Sometimes it takes you all the way at the end to swallowing difficulties. It's very important for you to keep up your speech and swallow. If you're having some choking episodes, you should absolutely tell your physician and get a swallow study. Tai Chi we spoke about. Anybody do Tai Chi here? It's very good. It's really excellent. Traditional Chinese martial art. Deep breathing, relaxation, but it also causes you to hold various postures. It's great for agility, great for balance, great for postural control. And there are clinical trials that show that Tai Chi does improve balance and motor outcomes in Parkinson's. Okay? It includes rhythmic weight shifting, symmetrical foot stepping, consistent movements, and it's a good activity. 7 clinical trials have reviewed the effect of Tai Chi on Parkinson's disease, and they have all found them to be safe and feasible in Parkinson's disease. They also, in one trial, compared conventional physical therapy to Tai Chi, and they thought that Tai Chi, if you can do it, had some important benefits in terms of postural stability and fewer falls. We talked about the tango, and of course, yoga. I do have patients who do yoga. Even if you can't do much, you might be able to do chair yoga. So I have patients who, even with advanced Parkinson's, can do chair yoga. Yoga is nice because it can be tailored to your own physical capacity. If Tai Chi is a little bit too hard, you can start out with yoga to increase your flexibility and strength. Okay? Anyone do whole body vibration? This is cheating. They have this machine that vibrates, and it exercises muscles for you. But there are people who can't do the exercises. So I can understand that. You stand on this machine, and the platform vibrates, and it causes your muscles, to move. Pretty much research has found that it improves leg strength, but, if you're going to exercise, you need to try to exercise of your own accord to the best of your ability. Uric acid. Urate has potential antioxidant properties. Higher levels in serum and CSF urate are associated with a lower risk of Parkinson's. This is being planned as a study, a phase 3 study. Okay, our last topic is vitamins. I'm surprised at how many patients I have who come in who don't take a vitamin, just a regular vitamin. So let's just go through quickly. So vitamin A is found in carrots and pumpkins, sweet potatoes. Vitamin A does have antioxidant properties, but it just hasn't been shown to be beneficial in Parkinson's yet. Vitamin B3 is niacin. So beer and coffee do have high levels of niacin. And of course, coffee has had an inverse association with the development of Parkinson. Please don't take this to mean that you should go drink beer. because it will poison your cerebellum, which is your balance center. B6, higher intake of B6 was also associated with a decreased risk of Parkinson's disease. The problem with B6 is that it can cause a neuropathy, and neuropathy is where you lose the feeling in your lower extremities. So I'd be very careful. I would talk to your physician if you wanted to go this route. Vitamin C is great for colds. It's great for, a lot of the things that we have, but there's no clear effect of vitamin C benefit in Parkinson's disease. You can't get kidney stones from it. It can cause some nausea and heartburn. Vitamin D, however, is clearly associated with the risk of Parkinson's disease, and we always look for vitamin D levels in Parkinson's disease patients, and we try to give them supplementation. So vitamin D is important to ask your physician about. If you haven't had a level, you may want to try to take a vitamin D level. Vitamin E, 30 years ago was thought that vitamin E may have neuroprotective and antioxidant effects. It was studied in a large study called the DataTop study, which failed to identify any neuroprotective benefit from vitamin E. Plus, vitamin E, if you take it, can cause anticoagulant properties as well. So vitamin D, as in dog, we want you to look into that. Vitamin B12, folate, also very important. Vitamin B12 and folate are important in terms of feeling well, gait stability, and neuropathy. Remember that vitamin B12 has a large range. So the normal range for vitamin B12 is 280 to 1,000. You may be 290 and you fall within the normal range, but we want you higher. So you may want to ask about a vitamin B12 level and a folate level from your provider. And we went through that and that. Okay, well, thank you very much. You've been a great audience. Is Robin here? Robin? Can I have Robin? Is Robin here? Now, I said that, I'm a Parkinson's disease daughter as well as a provider. And again, I want to thank NeuroChallenge and the amazing, amazing job that they do. And I have a foundation from my mom up in Tampa. And Robin, I'm going to donate, this is $1,000 to NeuroChallenge today for what you do.
Wow, thank you very much.
I know what it means to have a good provider, and this is a great organization. And thank you, Robin.
Thank you so much.
Anytime.
Thank you.
Okay, thank you.
That wasn't in the script, so thank you very much. And thank you for the amazing information, Dr. Zeschowitz. Well, this concludes our program, but before you leave, I just want to make sure that if you are interested in attending the Parkinsons Expo, that you fill out your registration form and leave it on your table. We'll be collecting those. And if you are able and willing and would like to help support our wonderful programs and services year-round, you can also make a donation. We thank you so much for being here, and thank you for being part of our community, and hope you have a happy and healthy remainder of 2018. Thank you.